So first I'd like to thank Craig Williams and introduce him to you. He's our hospital president, and he very graciously allowed us to hold this event here yet once again. And so Craig, if you would come up and say a few words.
Thank you, Isabel. I didn't realize this is actually my first time having an event like this until we had to sign for the liquor license.
Yeah.
And I actually read it. It was really intimidating what I was signing up for. So if anyone gets in any trouble, I want you to know I'm responsible for all you guys tonight. So. But seriously, thank you for being here at St. Edie's. This is an impressive event, Isabel, and I think it's really good to see everyone kind of getting together. Obviously, a lot of familiar faces amongst the group. So thank you all for being here, and I'll let you get on with the night. Thank you.
Thank you, Craig. Thank you for signing that. We can't have people stay after 6 o'clock without a glass of wine, so we thank you profoundly for signing off on that. And then I'd like to introduce Joe Weinstein, who most of you know, if not by sight, by name. Joe is our Chief Medical Officer, and he's charged with keeping us all practicing safe, high-quality medicine, and Joe will say a few words.
So, good evening, everybody. Thank you for coming. For those of you who don't know, I am Joe Weinstein. I'm the Chief Medical Officer for Steward Healthcare. My job is really very simple. My job is really to ensure that every patient gets a safe and high-quality experience. And, you know, it's not one of those things that's really very gray. I can kind of usually make those decisions pretty easily. And most of the decisions I make are always on the side of making sure that, again, we maintain the highest of quality and the highest standards for patient safety. When I think about my job, it's really pretty simple. I just try and figure out what's the right thing to do for patient safety. So for those of you that haven't really been paying attention, Steward has changed an awful lot in the last, 5 months. I'm sure you're going to see some slides in a couple minutes, which will give you a sense. But we have changed from a Massachusetts-centric company to a company that's really, got its footprint across the United States. We are the largest for-profit private healthcare company in the United States right now. We have 38 hospitals in 10 states. We have about 7,500 total beds. And we have just an incredible array of services that are provided predominantly and or exclusively for women's health. We range in size from a hospital that's got 22 beds in rural Colorado to huge inner city hospitals, the largest of which is St. Joseph's in Houston, which has 797 beds and delivers about 5,000 babies a year. They have a NICU which has about 50 beds and 48 beds, and their average daily census is 47. So gives you a sense of kind of where we are across the nation in terms of providing women's health. And again, we are absolutely committed to providing the highest in quality in women's health, whether it's in inner city Houston, whether it's in rural Colorado, or whether it's in Massachusetts. I know that some of you have been frustrated by some of the quality metrics that we have chosen to use. So I wanted to talk a little bit about quality and just, I won't take very long. So in this day and age, quality is not something that patients take for granted. It is assumed to be there. And if we don't deliver on the quality of promise, we're really not fulfilling the mandate that, our patients expect out of us. It's funny, patients know an awful lot about us before they ever walk into our rooms and before we ever examine a patient. They know our pictures from the internet. They know where we went to med school, where we did our residency, and where we did our training. And they know about the quality in the institutions that we practice at. They know about our C-section rates. They know about our episiotomy rates. They know about all the metrics that we routinely measure, and we ask you to help us in terms of providing high quality care. So while I can be frustratingly difficult when it comes to asking you to try and minimize those C-sections, to try and make sure that you're doing everything possible to avoid deliveries before 39 weeks, it is me that you can be frustrated with, but I'm doing it in part because it is providing high quality care. And I'm also doing it because Steward's reputation and your reputation is really now very publicly reported. So the information that patients have not only tells them where you went to med school and what your face looks like, but it tells them in terms that they can understand how you practice in terms of your quality. And so we are going to continue to move towards the highest in quality, the highest in patient safety. I am happy to debate any of the metrics that we've chosen with any one of you, so feel free to call me. If you think we're picking on the wrong ones, I'm happy to be part of that discussion, and if you're right, we should change them. But I do want to basically continue to drive quality, to improve patient safety, because again, this is how patients are looking at us in this day and age. The internet and social media are extraordinarily powerful tools, and people use them to influence their healthcare decisions. So I'm going to stop. If you have any questions, I'm happy to answer them. I'm happy to continue, talking about this offline, and if you have any questions, I'm happy to entertain any that you might have right now. So thank you.
Thank you. And then one more person that I'd like you all to meet, if you haven't already, Sanjay Shetty, who's my boss. But Sanjay is responsible for keeping all of us running smooth.
Hi everyone, thanks so much for coming out. It's always great to be back at St. Elizabeth's, which is sort of home for me. I was chair of radiology here for several years before. As Isabel mentioned, my role currently is as president of Steward Medical Group. I run the employed physician group for Steward. And I just thought I'd take a second. Joe did a great job of introducing sort of where we are right now. And it is kind of amazing to think, right? If I think back to what it was like as chair of radiology here at St. Elizabeth's and what Steward was, basically a system that at one point tried to sell itself for $1 and couldn't find someone to buy it. To being where we are now, a national system that is really recognized for so many things across the country, for our rapid growth, for the fact that we've committed to the idea of delivering high quality care in the community at a great value. Those are principles and concepts that are really becoming well known across the country, actually increasingly across the world. And it's been amazing to be with you, all of you, as part of this journey. So thank you for all of the work that you're doing every single day. One of the things that I'm most proud of about Steward is our tagline, right? So at Steward Medical Group, our mission statement, our little tagline is patient-centered, physician-led, community-focused. And that physician-led piece means a lot to me. Because I don't think of it as just me, I don't think of it as Joe, it's really all of us in this room, and more broadly, it's provider-led, right? It's all of us who are making those decisions every day, where you're kind of captain of the ship locally, doing what you're doing, and just to know that you are in a system that really respects the expertise that you bring to the table, that wants your opinion, that wants to hear the solutions you have to bring to bear on problems. I'm really, really proud of that. So thank you for being at a forum like this, where you get a chance to sort of continue to improve our game and make us better at everything that we do, and look forward to hanging out with you in the future. So thanks for all you're doing.
Thanks. All right. Thank you all for coming. I think it's important. We don't get opportunity too much. We see their names or get their memos, but it's nice to see them in person and get their updates on where we are as a system. Thank you all for coming. So this is my map. I didn't have your map. This is what they were talking about. So this is where Steward is now. The 11 hospitals on the left is the hospitals in Massachusetts, 5 of which do obstetrics, and the others do just GYN. And then these are the other hospitals that have been acquired. And this is where they are. And Dr. Baruda, I hate to tell you, but despite all your lobbying, you will not be going to Utah in February. I know. I think Dr. Cohen wants to go to Florida or Louisiana. He likes the warm weather. But for now, I think those of us in the room, we're staying in Massachusetts. So I thought I'd run through the hospitals and just have some updates on since the last time we met. What changes have we had in personnel or processes? So the big thing, and I'm starting at the north and just going south. And the big thing at Holy Family is that they started a laborist program on November 1st. The docs are very happy. It's had a couple of hiccups, but all going in the right direction. Hiccups meaning that it takes a little longer sometimes to staff it than you think it's going to, but all moving in the right direction. We're all very excited and all watching very closely because it could serve as a model for things that we can maybe learn from and do in other places even. So we're all watching very carefully. Dr. Shilpa Manga will be joining, has signed and will be joining the Steward Medical Group at Holy Family in the next, I don't know what her starting date is, in the next month or two. January 1st? Yeah. So hopefully we'll see her at the next meeting. And then as Dr. Baruta had a very successful day today up at Holy Family. So it was his first clinic, his first clinic at Holy Family. So we're very, very committed to reinvigorating the GYN oncology program up there and through other sites at the system. They were just readier to get it started. So we're launching it there first, but more updates on that to come. Anything else on Holy Family table? All right, we're good. So coming down geographically, St. Louis, I'd like to welcome Amy Kogut, who's joined us in the last month. Where are you, Amy? Stand up. No, that's Amy over there. She's joined us. We're very happy to have her. Of course, Dr. David Baruta, who's started with us in July. And hit the ground running, and then Dr. Adam Urado, who's a maternal fetal medicine. Where are you, Adam? There's Adam set up shop in Framingham. He's doing very well, and he works with us here as well. A couple other updates at SAMIC. We've had, as you all know, and I want to talk about NICU staffing challenges. You've probably all been frustrated about transferring your obstetrical patients to SAMIC at one time or another, and Craig left, but Craig understands the problems, and it's been mainly about staffing the NICU enough with NICU nurses so that we can accept the transfers. We have the beds, we need the staffing in order to have the right ratios to accept the transfer. So plans have been put in place to increase the staffing. And stay tuned, we should be able to resolve, as right now, Dr. Tesselta, we're closed at this moment, yes? We're capped for, if someone is going to deliver imminently, the patient cannot be transferred here, but if it's a high-risk patient who's not likely to deliver right away, that's different. But we'll continue, we understand that that's frustration, it's frustrating for the folks at SAMIC, it's frustrating for the folks across the system, because it impacts our normal workflow. It should be fairly easy to get your patients taken care of. We have a very clear system with processes in place to take care of any patient. And when those systems are not working well, it's frustrating for all of us. So I wanted to acknowledge it, that this is it's absolutely true, and it's a problem, and it is being addressed. And the other thing we're very excited about is we signed our second GYN oncologist. We still can't say his name?
As of last night, I was asked to wait one more week.
Okay.
But it was kind of sad that immediately when I came, you decided you needed somebody else.
I didn't want you to be lonely, David.
We're really excited. This candidate is a really awesome person. And so within probably a week or so, we should be able to be more formal. It's going to allow us to expand outreach, especially towards the southern part of Massachusetts. And this person has a skill set that I think is going to complement the current person. Well, I'm excited.
Yeah, no, it's excellent. The program is really doing well. It's very, very rewarding. Thank you, David. Good Sam has had a couple of additions as well. Dr. Joyce Profet, she may say it differently. How do you say it? Prophet. Okay. I try to be French, but who's not here today, correct? Actually, she emailed me. She's on call. Dr. Peter Brown, who's been last year. Dr. Ziad Fursan, I could not find a picture of you. Where are you, Ziad? You looked. We need to take a picture for next time. Dr. Lucy Bear, who you all know is still the interim chair at Good Sam, working hard. And then there's a new hospital president down at Good Sam, Doug Luckett, who has been very attentive to the needs in OBGYN and doing the best he can to make things better and run smoother. And then Morton Hospital, which is for the moment, at least for 2 weeks, this week and next week, the OB services have been suspended there, and that's because of lack of pediatric coverage. You can imagine delivering a baby without having a pediatrician available in case there's something wrong. So this was contract issue with Mass General and Brigham's and so on to align the pediatric coverage. So hopefully that'll be resolved soon. Meanwhile, thank you for the folks at Good Sam for making those patients feel welcome. It's a tight labor floor, so it can't be easy to absorb the extra volume, and thank you for making it all work. I understand it's actually gone as smooth as one could hope. So these are our C-section rates for, and we could pull the other metrics. Let's pull the one that maybe we need a little improvement on, right? Some of the others are doing really well on. And on the far right is our C-section rates for the hospitals for last year. And then the third year-to-date 2017 is on the left, and we've all tried to pay a little bit more attention to some metrics in the last quarter, and those are our numbers for the third quarter. So a little bit of improvement in most places compared to year-to-date, but clearly we still got some work to do. And we take care of very sick patients, and so that has to be considered. We have BMIs of 40 and 50 are not unusual, and and Joe Weinstein will tell you we'd rather defend a C-section rate than bad outcomes, that without a question. On the other hand, it's not to abdicate our responsibility or opportunities to do better for our patients where we can. So I think we can hold concurrently that there are some challenges in our patient population that are very real, and some numbers going to be irreducible, and at the same time accept that where there is room for improvement, we owe it to ourselves and our patients to pay attention and improve where we can. So what have we done so far? So we've reduced them a little bit across the system in most places. We've tried to delay inductions, especially of nulliparous patients, till after 41 weeks. You can do testing, after 40 weeks if you're uncomfortable. You can do BPPs, check AFIs, but especially folks with a lousy cervix, if you can wait till 41 weeks to induce them, that has shown to be able to make a difference. And honestly, I think that's the biggest reason we've seen some decreases already. Outpatient misoprostol protocol we're working on, so that'll decrease the inductions. Instead of doing 2 or 3 day inductions in the hospital, if we can have the patients come in, get the misoprostol, get monitored, and go home, I think that'll improve things as well. We've defined active labor as per the current data as being at 6 centimeters, so you don't have arrest of dilatation at 3 centimeters or 4 centimeters, active labor 6 centimeters. That'll help us not act too quickly on some patients. We decreased our time criteria. It's not 2 hours of pushing and you're done. If the baby's fine and the mom's fine, you can push longer without a set time limit. And of course, we encourage VBACs where it's safe to do so. So these are the things we've done. These are the things that are easier to articulate and to act upon because they're fairly concrete. But there's some things that are a little bit more difficult to act upon, and they take a little bit more education. Some comfort with operative deliveries obviously varies from practitioner to practitioner, but it's something that we can work on all becoming more comfortable with what are the indications, what are safe ways to do them. For most of us, that's going to be a vacuum, not forceps, unless you're trained with it. But within that context, we can all educate ourselves, have simulations, have prompts, and become more comfortable with those settings. And then there's that we all know what's a good fetal heart rate tracing, and we all know what's a bad fetal heart rate tracing. And then there's a lot of in between. And I've said many times, how can you say, I will never second guess someone who does at 2 in the morning a C-section for non-reassuring fetal heart rate. But what I'd like to do is be able to help all of us have some structure about identifying which are the tracings that we should act on and which are the tracings that we're okay to not act on. And it's education both of ourselves and of our nursing staff. So to that end, eventually, I'll introduce Tracy Pollard. Stand up, Tracy. Tracy is a nursing educator who I've known for a long time and has accepted the task of being a nursing educator coordinator, so that the same information that we disseminate here and we educate ourselves about can also be spread on the nursing side, because we've all been there where the nursing gets anxious about a tracing, the anxiety spreads to the patient, and we can't help but feel that anxiety as well. So obviously not to not act on the tracings where we should, but maybe give us a little bit more of a comfort zone, a little bit more structure on which are the ones we need to act on and which ones can we feel comfortable maybe waiting on a little bit longer. Okay. And to help us figure that out, we've invited our famous guest speaker, our favorite guest speaker, Dr. Bruce Cohen, who's going to speak to us about fetal acid-base balance and how we can all do a better job. Thank you.
All right, good evening, everybody. My name is Bruce Cohen, and we're going to talk tonight a little bit about fetal heart rate monitoring. And Isabel did a great job setting this up, and we know fetal heart rate monitoring on different levels. On one hand, they teach us in medical school and in our internship, this is an acceleration, this is a deceleration. But how sophisticated are we? Do we really understand the science? And if we can understand the science behind fetal monitoring, will we be more comfortable at 2 o'clock in the morning saying this is a good tracing, this is not such a good tracing? So we're going to talk about the science, and there are going to be parts that's a little dry, and I'm going to try to make them amusing. Okay, that's my job. And let's start by figuring out how to advance the slide. Okay, now, I wanted to get right to Maria Balzo. Okay, so there's always one in the crowd that says, well, why talk about fetal monitoring? It hasn't been proven to lessen the rate of cerebral palsy or fetal death. And the truth of the matter is, Maria, you're right about that, okay? But we understand this science, and we understand that we're not going to be able to prove this. And there's 3 main reasons. First of all, let's imagine that you're going to have a baby, okay? And I'm going to do a study, and we're going to put you in the group that doesn't get monitored during labor. No, you're not going to be in that group. So we can't randomize people to such a study. The other thing is the outcomes are so rare for what we'd be studying that we would literally need tens, if not hundreds of thousands of people to do the study. And there's a third reason. And the third reason is, in many instances, our opportunity to save babies from hypoxic ischemic encephalopathy or even death are missed because we don't really know what we're doing. Okay? How many times have you been in a room and heard somebody say to the patient, oh, I'm looking at your monitoring strip, and the baby looks totally happy. Okay, now, maybe I don't know everything about fetal monitoring, but in terms of a psychological evaluation, I'm not sure that we know whether the baby is happy or not, okay? So we don't know what we're doing, the outcome measures are rare, and we can't randomize. So if we're waiting for the proof that fetal monitoring is going to solve these problems, it's not going to happen. This is about trying to prevent injury to the brain. That's what this is about. We want to try to prevent cerebral palsy and fetal death by analyzing fetal monitoring strips. And what you can see from the slide on the upper right, oh, look at this, okay, is that very few cases of cerebral palsy have the potential to be prevented. Most cerebral palsy occurs before birth, some after birth. The amount that actually occurs during labor is relatively small. And we understand that we can look at MRIs, CTs of brains And we can understand what hypoxia looks like. And we even understand the pathway by which hypoxia generates free radicals which enter the cells of the brain irreversibly, even causing brain dysfunction, brain injury, or death. And we understand the circulation by which we're talking about here, that oxygen circulates through the maternal circulation to the uterine arteries in the uterus and the placenta, and from the placenta the oxygen travels down the umbilical cord and serves the cells and organs of the fetus. So we're going to talk now about the science of fetal heart rate monitoring. And the two areas that we're going to focus on are on two thrilling topics: acid-base physiology, okay, and understanding the adaptations of the fetal heart rate that go on. If we can understand these two concepts, we are going to be experts in fetal monitoring. And at the end, you're going to say, I'm an expert in fetal monitoring, okay? We might even ask it here. Okay, now, I'm trying to come out and present a relatively dry topic, acid-base physiology. Nobody clapped when I said we were going to start out by talking. And there's always one in the crowd that says, for the love of God, okay? So just stay with me just a couple of minutes here, okay? So in our cells of our body, we have the need for oxygen and glucose. Okay, no matter how we feel about carbohydrates, the energy of all cellular functions revolve around the delivery of oxygen and organic carbohydrates to our system. And there are two main systems by which we generate the energy of all cellular function. One is an aerobic system. Remember the Krebs cycle? Okay, so in the aerobic system, glycogen and glucose are broken down to form energy through the Krebs cycle, and this has to be in an aerobic environment, in the presence of oxygen. Now, one thing to notice is that the waste products of the Krebs cycle are relatively benign compounds, water and carbon dioxide. So glucose and oxygen enter the cells, and they are metabolized to form energy, carbon dioxide, and water. Now, when we don't have oxygen around, we use a different pathway, and that pathway is the anaerobic glycolysis pathway. It is a less efficient means of generating energy, for one thing, and it also develops waste products that are more difficult to excrete and to get rid of than the waste products of carbon dioxide and water. So what we see is that glucose enters the cycle, but instead of being degraded to carbon dioxide, we get acids, specifically lactic acid. So I want to begin to think of the fetal bloodstream as an organ of respiration. I'll tell you what I mean by that. What happens is we start off in the placenta and maternal circulation with oxygen and glucose. The oxygen and glucose enter our respiration center and in the bloodstream, and oxygen is bound to hemoglobin, and the glucose and the oxygen, which is released from the hemoglobin, enter the metabolism center of our body, the cells. So we have our respiratory center, and we have our metabolic center. Metabolism goes on where oxygen and glucose enter either the Krebs cycle and form energy, carbon dioxide, and water, and that just diffuses right out into the maternal circulation and is breathed out. Or it enters the oxygen independent cycle, and instead of, we have anaerobic glycolysis, which forms acids. The acids bind in an equilibrium with bicarbonate, another buffer, to form water and carbon dioxide, which then is excreted. So really, the fetal bloodstream is breathing in oxygen and breathing out carbon dioxide. And that's why I call the fetal bloodstream a respiratory organ in this sense. And we see also about the bloodstream that there's two main buffering systems. When oxygen is plentiful and there's not a lot of acid around, then hemoglobin binds oxygen very well. But as things become more acidic and oxygen decreases, hemoglobin lets loose of oxygen to maintain the level of oxygen. This is a buffering system based upon the acid-base status of the blood. Similarly, when there's not a lot of acid around coming from the metabolic center, most of this exists as bicarbonate. But when a lot of acid is produced, we have a buffer system where acid binds with bicarbonate to form water and carbon dioxide. So to take away from this slide, we have a respiratory center, the bloodstream, and a metabolic center, which is generating energy. So I want to talk about terminology, because when we want to talk to each other about fetal monitoring scripts, we want to know how to call things, okay? So let's start with our respiratory center, the fetal bloodstream. The fetal bloodstream. If we have low oxygen content in the fetal bloodstream, it's called hypoxemia, blood, like hemoglobin. If we have high PCO2 and acid, it's called acidemia. If we have a state of acidosis in the respiratory center, it's called a respiratory acidosis. This is our metabolic center, our fetal cells and tissues. If we have low oxygen in our fetal cells and tissues, it's called hypoxia. If we have high acid, it's called acidosis. And when this tissue has too much acid and too little oxygen, it's called a metabolic acidosis. And we can do a fetal blood gas, and we can see if we have a respiratory acidosis, the blood pH will be low, the oxygen will be low, the carbon dioxide will be high because it's built up, but the bicarbonate, our buffer, will be normal, okay? We're in a compensated system of buffering. On the other hand, if we are in such bad shape that we have a metabolic acidosis, we're going to have the same thing that we had with a respiratory acidosis, but we're going to have a low bicarbonate. So when you send your core gases, you can see what level are we at. Are we at a respiratory acidosis, or do we have a respiratory and metabolic acidosis? So this is to sum up our section. Okay, you can relax now. We're almost done with the acid-base physiology. Okay, so let's imagine that we have a fetus that's in the uterus, and for whatever reason, the patient takes cocaine, whatever reason, the placenta shears off. So now there's no oxygen exchange, okay? This baby is doing without oxygen. It's cut off from its oxygen tank. So the first thing that we're going to have is hypoxemia and acidemia. How do we get that? What is hypoxemia? Where? We have decreased oxygen in the blood, and we have a buildup of acid in the blood. Do you know where the acid's coming from? Our metabolic center and anaerobic metabolism. So in our blood, we have low oxygen and high acid. And we look to our buffers to rescue our behind, okay? And at first they do. And we just have a respiratory acidosis. Now, who gives a damn about a respiratory acidosis? It's not affecting the kid, it's just the bloodstream. As long as our tissues are well oxygenated, who really gives a damn? Okay, now we continue. There's still no oxygen coming into the system, and there's no way to get rid of the carbon dioxide because our placenta has separated. So we have anaerobic glycolysis going on, and we have hypoxia and acidosis. What's hypoxia and acidosis? Right, that's low oxygen and high acid in the tissues. And when we have that, we begin to form free radicals, and the tissue dies, at least malfunctions. All right, that's acid base. Okay, we made it through. Now, the next thing we're going to do is we're going to talk about fetal heart rate changes, and we're going to try to see, okay, I'll just tell you, one day I walked home, okay, and my youngest daughter, I discovered something about her, that she wears hair extenders. I saw this thing on the bed, okay, and I thought, this is the craziest thing I've ever seen. I thought it was some sort of animal at first. So I put it on, and she took a picture, so I thought, I'll use that for the lecture, okay? So can we use our knowledge of fetal heart rate changes to prevent severe metabolic acidosis? That's really the question here. We don't care about preventing respiratory acidosis. We care about preventing metabolic acidosis. There are 5 mechanisms that I want to go over so that we can understand these heart rate changes. One is the baroreceptor response, the chemoreceptor response, the response of the adrenal medulla, the battle between the sympathetic and parasympathetic nervous systems, and the cardiac failure response. So we're going to start off with the baroreceptor, and I'm going to try to give you things where you can remember what the heck a baroreceptor is. What I want you to think of is that the baroreceptor is like a nerd, okay? And this nerd is just focused on the blood pressure of the fetus, okay? So if the blood pressure falls, it fires to speed the heart rate. And if the blood pressure increases, it's firing to decrease the heart rate. And the idea is to maintain the fetus's cardiac output. So this very focused person is saying, oh my God, the pressure went down, I got to increase the heart rate. Or, the pressure went up, decrease the heart rate. It's very touchy, okay? So the baroreceptor is nothing but a pressure receptor increasing and decreasing the heart rate to maintain cardiac output. Okay, so what is an acceleration and a variable deceleration? So with an acceleration, the baby moves, stretches the umbilical cord. So here is a cross-section, ignore the word placental there. This is a cross-section of the umbilical cord. And you can see the very thin-walled vein and 2 pipes. These pipes are the umbilical arteries. They're not that compressible, but the vein is highly compressible. So when the baby moves and you stretch the cord, the vein collapses, but these pipes stay open. So what happens is, when the vein collapses, all the blood rushing back to the baby's heart falls because the vein is closed. The pressure goes down, and the baroreceptor says, for God's sakes, raise the heart rate. The pressure is down. So this is nothing but a response to the umbilical vein closing, the pressure going down, and a need to increase the heart rate to maintain cardiac output. A variable deceleration is the same thing. Okay, the uterus contracts and the cord is compressed. When the cord starts to be compressed, the vein closes first. When the vein closes, the blood pressure goes down, so we fire to increase the heart rate. Then, as the contraction continues, the arteries contract as well. This increases the blood pressure, so those darn nerdy baroreceptors drop the heart rate to maintain the cardiac output. As the contraction abates, we see these pipes pop open first, and so we have to increase the heart rate because we have low blood pressure because that's closed, and then it comes back to a stable state. So what you can see is that a baroreceptor response is nothing but a response to pressure to maintain cardiac output. It has nothing to do, in the purest sense, with acid-base physiology. What about a chemoreceptor response? So if a baroreceptor response, we're going to remember this nerdy ledger keeper trying to keep track of the cardiac output with increasing and decreasing pressure, the chemoreceptor response is like a bear. Now, why does a bear hibernate in the winter? What happened? There's not a lot of food around, right? Not a lot of energy to be had. So to conserve energy, when there isn't a lot of food around, that bear wants to lower its metabolic rate so as to conserve energy. Well, the chemoreceptor, which is also on the aorta, is a similar type beast as that bear, okay? So when there is a decrease in oxygen or an increase in carbon dioxide, that bear wants to decrease the metabolic rate because it's like, hey, there's not a lot of oxygen around, I need to chill, okay? So it is going to decrease the fetal heart rate in response to a decrease in oxygen. So what is a late deceleration and what is a bradycardia? This is nothing more than the slowing of the heart as an adaptive mechanism to use less energy, okay, in the setting of decreased oxygen and increased carbon dioxide. And one thing just to mention is you can see that a late deceleration descends towards the peak of the contraction at a time when there's the least amount of exchange of oxygen in the placental vessels between the maternal and fetal circulation. Okay, now the adrenal medulla response. Who knows who this is? Who's that? Chris Farley, that's right. Okay, now an adrenal medulla response is our fight or flight response. So sometimes in response to a decrease in oxygen, we have a pathway that leads to fetal tachycardia, the release of catecholamines and so forth. So we can see in this picture that maybe in response to a preceding hyperstimulation or something, we're seeing that fight or flight response and a fetal tachycardia. Now, the sympathetic parasympathetic struggle. In the well-oxygenated brainstem, there is a fight between the parasympathetic nervous system that wants to slow the heart rate and the sympathetic nervous system that wants to speed the heart rate. And that is expressed as the variability. So we have Tommy Chong here that wants to slow the heart rate, and we have a very perturbed businessman that wants to speed the heart rate. And what we can see is that we have these little squiggly lines. That is good variability. That is the interplay between the parasympathetic and the sympathetic nervous system. And if you remember nothing else about this lecture, you want to remember that a well-oxygenated brain has good short-term variability. When you look at this picture, there's no variability. And the reason that there's no variability is that this brainstem is not well oxygenated and is disturbed by a severe metabolic acidosis. The final thing that I won't say a lot about, when you reach a point where you're in a very acidic environment, the tissues of the heart musculature do not perform well. And we see decelerations in the heart because the heart just does not have enough energy to beat properly. So that the cardiac dysfunction, what I want you to think of cardiac dysfunction, you look at a strip like this and you say, where is the baseline? It's like you have an adrenal response to raise the heart rate, and you have a chemoreceptor response like the bear to decrease the heart rate. You don't really have a baseline. This heart really isn't working well. It is in a severe metabolic acidotic state. So now we have to apply labor to this situation, okay? And labor is a stress test for a baby, okay? And what I want you to think of is we talked about baroreceptor responses, which are either cord occlusion or squeezing of the cord from a uterine contraction. But in labor, we have to think that if you had a baroreceptor response that went on for long enough that you weren't oxygenating the fetus, you would have a chemoreceptor response in addition to your baroreceptor response. And so while we have said, okay, this is an acceleration, this is a variable deceleration, this is a late deceleration, in the practice of obstetrics, it's not that often that we see in the second stage of labor a reactive tracing, and it's not that often that we see a category 3 tracing. Most of things are category 2, and wouldn't it be nice to be able to really describe them and really get a feel for what's going on? And so we need to appreciate that there are mixed responses, things that are part baroreceptor, part chemoreceptor, and begin to talk about them. So it couldn't make the lecture without the categories, because this is a way that we do talk about strips. Category 1 are just baroreceptor responses, okay? A reactive tracing, we're not going to see that many of them in the real throes of labor. Category 2 is a loss of reactivity or chemoreceptor responses with good variability, or loss of variability without baroreceptor or chemoreceptor responses. And category 3, the hallmark is that loss of variability, that loss of the well-oxygenated brain to have a struggle between the parasympathetic and the sympathetic nervous systems. So now I'm going to summarize the science. Now I'm going to have to ask for your, I'm going to apologize in advance. I have 3 slides that in a very boring way I'm going to read to you, okay? And maybe we should take a break between the slides or something. But this is going to summarize, and this is going to encapsulate all our science. And then we're going to have fun, okay? We're going to look at strips. Okay, so oxygen and glucose travel from the maternal bloodstream through the placenta and into the fetal bloodstream to generate the energy for all fetal cell functions. That's fairly self-explanatory. Under normal circumstances, oxygen and glucose diffuse into the cells of the fetal organs where they generate ATP through the process of aerobic glycolysis, producing CO2 and water as waste products, which can easily diffuse back through the maternal circulation. Now, when oxygen delivery is initially compromised, a buffer system exists involving hemoglobin dissociation and organic bases, bicarbonate, maintains normal fetal tissue oxygen levels. The low oxygen and high acid levels in the bloodstream they're called hypoxemia and acidemia. Because the bloodstream is the organ of gas exchange, when you have this issue in the bloodstream, it's referred to as a respiratory acidosis. Okay, now I'm going to change venue. I'm going to stand on a chair just so to do something different so that we can exist through the second slide. Okay? You should be nervous. I'm feeling a little shaky. Okay? As the oxygen deprivation progresses, the buffer system is overwhelmed and there is low oxygen delivery to the fetal tissues. This results in anaerobic glycolysis with a buildup of organic acids in the fetal tissues. The low tissue oxygen is referred to as hypoxia, while the high acid content is called acidosis. Low oxygen and high acid content in the tissues are the components of, there you go. The brain and heart are highly oxygen dependent. Cardiac hypoxia results in cardiac failure and infarction, while cerebral hypoxia results ultimately in irreversible brain injury. If these injuries are sufficiently severe, the fetus will die. By understanding the functions and physiological adaptations associated with baroreceptors, chemoreceptors, the cells of the adrenal medulla, and the parasympathetic and sympathetic nervous systems, we can use continuous fetal heart rate monitoring to distinguish the fetus who is normoxic from a fetus with respiratory acidosis from a fetus with a metabolic acidosis. The baroreceptor response maintains cardiac output by raising and lowering the fetal heart rate in response to blood pressure changes. Baroreceptors mediate fetal heart rate accelerations and variable decelerations, and in their purest form, baroreceptor responses have nothing to do with fetal acid-base physiology. I'm coming down. Okay. Now, chemoreceptors decrease the fetal heart rate in response to fetal hypoxemia and acidemia to conserve energy by decreasing the metabolic demand for oxygen. Chemoreceptors mediate most late decelerations and fetal bradycardias. What animal does a chemoreceptor resemble? A bear. Good. An increase above the normal fetal heart rate baseline may be the result of an adrenal stimulation by the medulla oblongata of the brain in response to fetal hypoxemia. However, fetal tachycardia may be the result of maternal fever, exogenous medications, and a bunch of other things. Fetal brain hypoxia may interfere with the sympathetic parasympathetic nervous system struggle and decrease or even abolish short-term fetal heart rate variability. Most important, fetal cardiac muscle hypoxia may lead to late decelerations with a notable lack of fetal heart rate baseline variability, or combined with an adrenal response with loss of the fetal heart rate baseline as a reflection of an uncompensated decrease in fetal cardiac output. Category 1 is a reactive fetus. Category 2 is a fetus with good variability with periodic changes, or abnormal variability without periodic changes. And category 3 is abnormal variability with periodic changes. That's all the science. That was it. Okay. Now we're going to have fun. Okay. So, come on. Okay. So, okay. Now, we're going to have fun and games time. Okay, this means will not be bad, I promise. Never do anything. Okay, a patient presents in early labor. Okay, let's talk about, and you'll lead the discussion, all the things that we notice about this strip. What do you think about this strip?
I think it's a good strip. When I start with the strips, I always start off with what is the fetal baseline.
Okay.
And then I look at the variability, and then I look at the contractions and with the response that the fetus has to the contractions.
That's excellent. And now, that was great. You can sit down. You did a great job. Okay, now, when we look at this strip, okay, we see these things right here, okay, and we see the heart rate going up.
Happy baby.
It's a happy baby, exactly. So these are accelerations. What do we know about accelerations? What's the deal with accelerations?
It's a baroreceptor response.
You are right. Sit down. You did great. We've got a baroreceptor response. So we have some contractions here, and we're having a baroreceptor response. And is there anything about this strip that talks to the acid-based physiology and the physiological state of the baby? Do we have a fetal heart rate baseline? So we have one. It's not as if the thing is all over the place. Something is regulating a fetal heart rate baseline. And is that baseline squiggly? Why is it squiggly? Good variability. What is good variability? So, do you know who Tommy Chong is? You do.
I do.
You do. And he was on Dancing with the Stars recently. Okay? But that was from the movie Cheech and Chong, okay? The movie Up in Smoke, where these two guys smoked marijuana all the way across the United States. So this is the interplay of the sympathetic and parasympathetic nervous system. If you have good variability, what does it mean physiologically? We know we have good parasympathetic and sympathetic variability. We know that the struggle is going. What does it mean that that struggle is going on? Well-oxygenated brainstem. Is there any question that this baby has a well-oxygenated brainstem? No. Of great variability. We see some baroreceptor responses. They're not mixed responses. This has nothing to do with acid-base physiology. This is a well-oxygenated baby. All right, let's go on with our labor. Mr. Urano, come right up. Come right up. Okay, this is Adam Urano, a great guy and a great MFM doc. And his training, he trained in a place that he's not proud of. It's okay. Okay, so we're just gonna have a general conversation. We're just walking down the street, okay, about this strip right here. So we said at Tufts she would have been sectioned hours ago. Okay.
Section.
Exactly. Okay.
I think it does.
Okay, good. That's a good start. Now, what do you notice about this strip? We got, first of all, we'll start at the bottom. We got.
She's contracted.
She's contracted. Okay. And then we go to our variability. What do you think?
I like it.
Okay. So we got good variability. And what does good variability mean? Good oxygenation of the brainstem. Excellent. Okay. He's a gynecologist, but he knows his own name. Okay?
Did residence.
There you go. Okay.
He taught me during residence.
He didn't forget
He
either.
was a year ahead of me.
He's got so much trauma, it's a wonder he's here. Okay. Now, we see these little dips right here. I mean, these could be early decelerations, but whatever they are baroreceptor responses. This is just a response to pressure. So this is a great baby. You don't need dissection. Okay? Thank you so much, Adam. You can sit down.
What am I hiding? Am I?
Do you have a cup of coffee? I took that picture of you last week. Okay. Now, Catherine.
I think she left.
No, she's right here. What do you think? We've got, what is this deceleration right here? You can get a consult if you need it. Anyone in your table.
Are there any periodicologists?
There are. You've got Adam sitting right next to you. This is what kind of deceleration is this? What was that? Variable deceleration. Okay. And we know this is just a response to pressure. Is there anything with regards to acid-base physiology? Is this baby hypoxic? No, we have great variability. And we know this is just the twinking of the cardiac output by raising and lowering the blood pressure. So we're going along in labor, and we have a variable deceleration. Now, here the patient speaks to us. She says, I'm always jealous of the anesthesiologists because they're the heroes of labor delivery. I feel so much better after that epidural. That anesthesiologist is my hero. Okay? Now, let's go. We need the right person. And I have just the right person. Come with me. Okay. So, what do we got as we look at this? We'll start at the bottom. Okay. We got these little things like, okay, she's contracting. And we've got a baseline here. And how about our variability? Do we have a well-oxygenated brainstem? Yeah, we do. Okay. And we got some things. We got late decelerations. You did great. Sit right down. That was excellent. 100%. That was excellent. Okay. All right. Now, we have late decelerations with good variability. So what's going on? What is this? Why do we have these late decelerations? Maternal hypotension. Okay, great epidural, right? Excellent epidural. And the blood pools in the legs, and we have maternal hypotension. And what happens when we have maternal hypotension? Less oxygenation. There's less perfusion of the uterine vessels. There is low oxygen, and there is a buildup of carbon dioxide. And what happens? What is are these baroreceptor responses? Chemoreceptor responses. We can tell that because that bear usually has just a more gentle slope than the variable decelerations. Now, why is always these chairmen with "I'll kill you"? There's always if you do this, I'll kill you. She has to kill you. That's the main thing. So if you section her now, if you're at Tufts, okay, where Adam trains, okay, then you're going to section the patient. But what is going on? The patient has hypotension. We have a decrease in oxygen flow. We have an increase in carbon dioxide. We're having a chemoreceptor response. Is there any evidence at all that there is hypoxia? Is there any evidence that there is acidosis? Is there any evidence that there's hypoxemia? Why do you get a chemoreceptor response if you don't have hypoxemia? So the chemoreceptors see the blood going by, and they see hypoxemia. They see low oxygen. Is there acidemia? So this is a patient that is having transient hypoxemia and acidemia picked up by the chemoreceptors and firing late decelerations. But there's no hypoxia. There's no acidosis. So let's try to change things by raising her blood pressure and reversing the hypoxemia and acidemia. Remember, nobody gives a damn about a respiratory acidosis. That doesn't affect the tissues. We don't have a metabolic acidosis here. So let's try to change things around and keep this labor going. All right. Now, who knows this song? Can you sing a couple of bars? Dr. Testa, you know the song?
Yes, but I don't know how to sing.
Put your head on my shoulder. Okay, now, who wants to take this one on? Anna? Okay, Anna, we have this situation right here. We have some contractions, okay? And we've got a baseline here. There's a baseline heart rate here. We even see an acceleration, and then we see this puppy that looks like a variable, doesn't it?
I know it's an early variable.
Early variable, all right. Variable by any other name would be as sweet. And then we got this puppy. What is this? We see it again here. What does that look like to you? What do you think is the cause of this shoulder? This is an adrenal response, okay? So what you see is there's enough going on here that the baby gets a little low on oxygen, and we fire the adrenals so that when this puppy goes back, it actually overshoots. So this would be a complicated variable deceleration. Now, Kathy, we see that is this a variable deceleration? This is like kind of a subtle, what are you thinking? Bear, okay? This is a chemoreceptor response. So even though it sort of looks like a variable, its behavior here is more like a chemoreceptor response with a little adrenal overshoot. So now we've gone from having pure variables to having variables that are kind of mixed, okay? And we'll go on with our later. Okay, now, Helen.
Want me to sing reference of quarterback?
Do you know what quarterback does?
Oh, sure, our famous one.
Calm bradycardia. This is a Brady, okay? So what we see is the heart rate goes down and slow upstroke. Is this a barrier response? Okay. Is this an adrenal response? These are your chemoreceptors. Okay. Your chemoreceptors, something happened here. Maybe there was a small abruption. Maybe there was a prolonged leaning on the umbilical cord by the baby. Something went on that triggered the chemoreceptor response. But we can see after the response, the variability is good. Is this baby hypoxic? Is it got acidosis? No. This baby is perfectly fine. We did get a chemoreceptor trigger. We might want to think, well, what caused that? You know, are we seeing any vaginal bleeding? Is there some sort of reason? But at the same time, we want to get a sense of where we are in that pathway. We're not at acidosis. We're not at hypoxia. Okay, now we've got some new. Who's going to take this on? What do we got here? Well, we've got things that sort of look like variables accelerations. We've got some decent variability, and they look, you know, variables are often called variables because they all look somewhat different. Some of them sort of seem to be coming late, almost in a pattern. So this is a very suspicious. Is this a category 3 tracing? No. Why not? You've got good variability. So it's not a category, but what is this? Are we hypoxemia? Do we have hypoxia? Do we have acidemia? Do we have acidosis? I think we've got a wash. I think these are mixed variables with some chemoreceptor response. Turn down the pen. Okay. Now, let the second stage begin. Okay, let's get the party started here. What do we got here? What's that?
Deep variables with contractions.
Okay, you've got deep variables. What else do you notice about this? Okay. I'm sorry?
Loss of beat to beat.
Loss of beat to beat variability. Sure. Very good. Okay, good.
You need forceps.
You need forceps?
Quicker than the OR.
The patient is at +1 station right now, but okay.
Call Dr. Edward.
There you go. There you go. Okay. So we're starting to see, at least to a certain degree, there's some areas that have some variability. And who wants to just take on, let's just look at each contraction and see what's going on. What do you see in this contraction? Anything of note from your experience as we've looked at these strips? Yes, you have some overshoot. So we've got a baroreceptor response, a quick downgrade that lasts the length of the contraction. It's very deep, and we talked about if you have deep enough baroreceptor responses, you're going to elicit a chemoreceptor response. And in this case, you have a baroreceptor response that elicits an adrenal response. And then we go, and what about here? What do we have here? The heart rate here is like 180. We're tachycardic here. Why are we tachycardic? Depression? The pressure? The pressure of the whole situation? Okay. Right, the adrenal gland. Okay, so we're seeing sort of an adrenal response here. This baby is having some stress. Okay, and when we look here, we see, some areas of really poor variability. Why do we have poor variability? Right, what's going on in the brain? There's malfunction of the parasympathetic and sympathetic nervous systems of the brainstem in response to a certain degree of acidosis and hypoxia. So if you had to look at the blood gas right now, what would you be thinking as we make our way here? Well, the patient feels warm, now we're a little tachycardic. We've got this. What do you think as this patient is now in the second stage of labor? what do you think the arterial blood gas would be? Would we have normal oxygenation? We've just started the second stage of labor. We've just started this. Do you think we'd have a metabolic acidosis this quickly? Or would we have a respiratory acidosis? So when we look at this, we see the pH is decreased. The oxygen, partial pressure of oxygen is decreased. The partial pressure of carbon dioxide is increased. And our bicarb is normal. This is a respiratory acidosis. Let's go on. Now, this pattern, okay, right, this pattern here is beginning to look very worrisome, okay? So, what bothers you, Dr. Testa, about this pattern right here? Okay. So,
whether kill me or not kill me.
Okay. So, what's going on now? Tell me clinically, you look at that pattern, what do you see about the pattern?
Well, we have deep deceleration. I don't see any contractions. I assume that they are somewhere.
Right, maybe we can't take it out.
I see pattern.
And what is the pattern? What are these decelerations? These are variables. So what kind of response would be a variable response? Are these baroreceptors, chemoreceptors, adrenal responses? Is this telling us something about the baby's brainstem? What do we got here?
It's mixed. Lots of variability in deep variable, overshoot, and baseline.
Okay, but what clinically? Do you see baroreceptor responses here? Is there an attempt to maintain the cardiac output? You sort of have a variable deceleration look. Do you see evidence of chemoreceptor responses? When we look at some of these things in here, and just at some of the way things descend and go back, do these look like the pure variables that we saw earlier on in the labor? Or is it, when we look in here, are there areas that just don't look like pure variable decelerations? And somebody mentioned the overshoots. These are very high heart rates. So there's an adrenal component here. We're seeing baroreceptor, chemoreceptor, adrenal medulla responses. And what about the parasympathetic and sympathetic nervous systems? What are they doing? They are a little depressed right now. The variability just isn't that great. And what about the function of the heart overall? Is the heart able, in working with the brain, to establish a baseline? Are we beginning to see that beginning of a pattern where we're losing the baseline, where cardiac function, that this heart is so acidotic that it can't function well? Okay, so this is what the strip then becomes. Who wants to take this one on? You're good. You're very good.
Yeah, we're going to the OR.
Okay. Look. What do we have going on? Can you discern the physiology here? Can you distinguish baroreceptor from chemoreceptor response here? Right. Where is the baseline? There's no fetal heart rate baseline. This heart is so acidotic that the muscular tissue of the heart cannot function properly. What you're seeing is the descent in cardiac output, and then an adrenal response, an attempt to secure cardiac output, and then the heart falling, not able to contract properly. So this is a want to get away. And then we look at the pH and we see that we have a metabolic acidosis. And we didn't need to get the blood blood gas to know that. We can see that the muscle can't function. So this is a terminal bradycardia, okay? And this is the end of the baby's life, right there. So this sort of took you through the beginning to a strict placenta that could not support a baby through labor. All right, now we're going to do the rare and scary. She's getting up because she's scared. There's a lot of people that don't like a horror film. She's not. Are you scared? Okay, good.
Are there any more wine?
All right. Give her a little wine because she's going to take on the next slide. Okay? So what is going to be rare and scary? Okay. What do you think of this one? The patient comes in labor. She's contracting frequently, and you see this. So this is, the patient isn't even dilated, and you see this strip. What do you think of this strip?
Unattractive.
What's that?
Unattractive.
All right, that's a very good response.
What's medication?
She's on no medication. The patient has just walked into the unit, okay? What's that?
She might be self-prescribing something.
She could be self-prescribing something. But basically, this is an external monitor, okay? And so it will tend to exaggerate the variability. You have a flat line. You walk in, they say, oh, there's somebody here to see you on labor and delivery. She's in early labor, and she presents, and you see this. And it's a flat line.
Is that tachycardia?
It's sort of towards the top part, yeah, maybe a little tachycardic. Okay, now if you had an abruption, what's going to happen is you're going to develop low oxygen, right, and high bicarbonate, just like in our, remember we talked about the baby that had the abruption. And you will get a chemoreceptor response, right? Do you see any baroreceptor response? Do you see any chemoreceptor response?
No brains.
Right. No brainstem, nobody home. So this is an excellent candidate for Harvard. The second kid's going to go to Harvard, okay? Because this is not good, okay? This isn't an acute hypoxia. You don't see chemoreceptor responses. You don't see a bradycardia. You don't see decelerations at all. This is a baby that has had an injury to its brainstem, and it has no variability. But it's not in a setting of hypoxia. This is the injured brain. Okay. The patient walks in, and you say this. You think, I'm late to the party. Okay. This is a pre-death pattern, essentially. This is going to turn into a loss. This barely has a baseline. You see absent variability because the brain is hypoxic. You see decelerations because it's acute hypoxia. And this baseline is about to disappear and the baby is about to die. What about this? You walk in, the patient walks in the unit, they put the monitor on, and you see this. Well, that's a pretty nice thing. So you put the ultrasound on the baby's heartbeat. What do? She's 34 weeks. She came in because, she thought she might have been exposed to somebody who was exposed to somebody that had the Zika virus. She came for her evaluation, and she's 34 weeks, and she comes to labor and delivery, and you put her on the monitor, and you see this. So let's go back to our basics. Do you see a baroreceptor response? Do you see a chemoreceptor response? Do you see an adrenal medulla response? There's some variability there. Is there a shutdown of the parasympathetic and sympathetic nervous systems? There's some variability. So it's not a shutdown of the parasympathetic, sympathetic nervous system. It's not a baroreceptor response. It's not a chemoreceptor response. It's not an adrenal response. Does this have anything to do with the oxygenation of the baby? You rush her to the back and do a C-section? So we have to, so this is not an acute hypoxia, okay? This is somebody who either, has some sort of arrhythmia or something. This needs an evaluation. This is not the patient to rush. This is not a bradycardia. This has to do with fetal anemia, and it's just something sort of pattern recognition. And this is what it's all about. Cute little baby. Thanks so much for your attention.
Questions for Dr. Coleman?
The mechanism for fetal scalp stim. So when they say not a good pattern, in 30 minutes we'll do a fetal scalp stim or the vibroacoustic stimulation. So that's parasympathetic and sympathetic as well.
Well, the parasympathetic and the sympathetic are that interplay. That's your variability.
Yeah, but that's
How do you get the heart rate to go up? Is it a baroreceptor response? Is it acoustic stimulation? Squeezing the cord? What do you think of? What's the baby? Ah! See, your heart rate went up, okay? Because we had a fight or flight response.
So the adrenal.
There you go.
I'll remember that.
You're not going to forget that one. Anybody else? Okay, thanks so much.
Thank you.
Everybody on their way out, if you want to head by security, which is just at the front, they'll validate your parking passes. Not kicking anybody out. Okay?
Sorry, well, you picked the right person.